Hey, everybody. Welcome to DocTalk. I'm Dr. Erin Knopf.
I'm Dr. Corinne Hannan.
And today we have an incredible legend joining us. Dr. Wendy Oliver-Pyatt is here to talk about virtual care and this new frontier that is having so much more traction. Thank goodness there's something good that came out of the pandemic. Dr. Wendy Oliver-Pyatt, how are you? Thank you for joining us.
It's so fun to be with you both. Thank you for having me.
We couldn't be more thrilled. Okay, so tell us a little bit about your background, what got you here, and then we'll dive on in.
Sure. So I'm a psychiatrist and I did my residency training back at NYU ages ago, decades ago. And I really became a psychiatrist out of just a deep passion and concern about those affected by mental illness. I did not, contrary to what a lot of times people think about my background, like, oh, did you become a psychiatrist because you wanted to treat eating disorders? Absolutely not. In fact, if you would have asked me then, I would have said I absolutely do not want to treat eating disorders explicitly. I really loved working with severe mental illness, and community mental health was my initial passion. But over the years, I ended up doing some private practice work in the area of eating disorders. I did have my own past history of having had an eating disorder, going back to really around 8th grade up through about second year of medical school. So in my private practice, I just sort of had a knack for it, I guess you could say. And then it was sort of one thing led to another, and the idea was presented. Actually, somebody asked me, did I ever want to work in an inpatient hospital? And a little guardian angel came over to me, and I just said, I don't want to work in a hospital because all you would do is correct the potassium and discharge the person. I want to dig in. So I was like, I would do residential. So that was when I started my first residential program. It was a very unplanned, very organic process for me.
Wow. I'm just thinking as a clinician, falling into that, oh my gosh. And especially when you founded OPC, that was amazing. There weren't a lot of women starting initiatives like this. So for me, you are a trailblazer, truly. You're the only female psychiatrist CEO I know. You might know some more, but you're the only one I know.
There's been some. Kim McCallan was around, and
oh, that's true. That's true.
Yeah. And I actually started another treatment center in 2003. My first center was called Center for Hope of the Sierras, which was in Reno, Nevada. So that was how I kind of stumbled into the field, and I've never really looked back, honestly. I do now work, and I also provide primary mental health in one of my programs, not within, but in another program, Galen Hope. And that's also really nice for me because I've always been just truly a lover of mental health issues in general, and just a lover, not lover of the issues, but lover of helping people heal and go on to thrive, and just the power of the relationship and the power of the brain, and putting together treatment programs that help people heal is just such a delight. And seeing people heal and working with the teams, it's just really an honor, and it's something I enjoy so much.
You're an inspiration. Thank you. And yeah, you're not busy at all. It's fine. So you've seen so many modalities and ways for people to connect through this recovery journey.
Yeah.
What is telehealth in your definition today? What is it really like? Because those who don't know really don't know. And can you tell us a little bit more about the advantages, disadvantages you're seeing currently?
Sure. I would be so happy to do that. I think it'd be remiss for me to not tell you a little bit of the origin of how this whole idea of Within came to be, which was even before the pandemic. I started doing some private practice, and I was encountering many patients from all over the place. I had a woman that was actually a dolphin trainer, and there was no way she was going to be able to leave her job, and but she really had a very serious eating disorder. And I started seeing her at a high frequency throughout the week, and I was sort of wearing psychiatrist, therapist, dietitian. I was covering a lot of bases with her on a high frequency. And it was sort of I just didn't know how it was going to go. And I was like, I'll be darned. This woman is getting better. And I wasn't sure if it was going to be helpful to her or not. And I realized it was really having this effect. So I call it remote. I intentionally call it remote, not virtual, because virtual implies not real, whereas these are very real relationships. So I call it remote care versus virtual. So that got me really thinking pre-pandemic, what can we do in a remote way to be more helpful and reach more people? And then the pandemic came, and then it was necessity was the mother of invention. And And we realized that there was a way I felt it needed to be done in order to be done in an effective way. And I was very concerned about like the pop-up model of just, just doing it flying by the seat of your pants, which I'm not I mean, that was what we had to do. But I felt like this was an opportunity to really think about like, what's the foundations of care that you experience in like a brick and mortar that you need to figure out how to make available in the home? Like, what are the principles of care that need to be stood up in a remote setting, and how does that look? And so we are an intentionally remote program at Within Health. And as you dive into the program further and you get to understand it, you see so many elements of like the meaning of different things that happen in a brick and mortar coming alive at Within.
Yeah, if you can comment a little bit on how you translated PHP or partial hospitalization programming and intensive outpatient programming into that remote model. I think everyone here would love to know more about how you created.
I call it enhanced PHP and enhanced IOP because it does our care model goes far beyond a traditional PHP or IOP care. It's not like, 3 hours here or 6 hours there. It's not like that at all. And the way I did it, it was a group of us. So I don't want to say I did it. It was like a lot of people. But the concept I asked for people to kind of wrap their heads around is like, I literally, in my mind, took myself to the front door of OPC. And I was like, what's inside? Like, what's in here that the patients are experiencing that's creating this like magic and this experience for this healing environment? And how am I going to create that, in the home? And what do we need to do? And it was actually really fun too, because we created an app to be kind of the foundation of all the connections. And I had just the delight and the pleasure of like working with developers who didn't know anything about the space and just sitting there trying to describe like, okay, we need to do a medical clearance and we need to do an admission assessment, and just kind of taking them through the workflows that you have in a brick and mortar and translating it into this remote setting. But some of the things that were really, really important to me that are true between in-person or brick and mortar is just the high frequency of individual therapy, small milieus, not diluting it out, really effective communication and multidisciplinary communication with intra-organization and also outside of the organization is really, really important. I thought it was really important to bring nursing in because we work with very high acuity at times. So having nursing and remote monitoring was going to be really important. I've always really believed in the importance of like the monitoring and support around the medical, because not only are these really dangerous illnesses, but it's really important for people with eating disorders to not be blind to the physiological effects of the condition. And I just was saying with the team earlier, look, if somebody's purging, they're going to have to get labs. So I think it's really important to be really making sure, because it's also psychoed, it's that whole thing of you're fine. And well, actually you have orthostatic hypotension. You're not fine. So the medical piece was really important to bring in. And then the community setting. So there's a real community feel our patients, I think, experience at Within that we're really intentional about creating ways for them to communicate, not just during groups, but we have some other ways of like creating that feeling of being in that living room in between sessions so people can connect. So
the schmooze time.
Schmooze time is important. And we have chat features and things on our apps. So it's like, let's say I want to talk to my dietitian. Well, in a brick and mortar, dietitian might walk by and you could say, hey, quick question. Well, we have some ways of doing some communication and support and monitoring, in between the more traditional functions.
So when you said you wanted to bring the principles from, in-person treatment into the remote care, you mean like this frequency, availability, high quality of monitoring, communication, and then also like the small milieu.
And the cohesiveness of feeling like I'm a patient. This is my group. This is my team of clinicians and also my peers, that I'm forming relationships with. And I think that brings about to our commitment to alumni. So the folks can really create these connections and then be in different alumni experiences post-discharge. It kind of keeps that all the pillars of recovery that you want to reinforce that you get in treatment and really have access. Okay, what are those foundational things? what were the paradigm shifts that I kind of went through in treatment? How do I keep that paradigm going in this fat phobic culture that's, constantly bashing me around? How can I hang on to like the pillars of care?
And my safety and my
Yeah.
beautiful. That's so well said.
Thank you.
It's so interesting too. I mean, from being at in-person higher level of care, historically, it's hard to keep in touch with peers and your cohorts when you leave. In fact, it's even kind of against the rules sometimes, depending on the milieu.
It's almost pathologized and
yeah. When really it's necessary. It is one of those extra legs of recovery, to have that person there.
Thank you for bringing that up. I mean, obviously, you have to check all the boxes. You have to assess medical, legal, blah, blah, blah. All that stuff matters. But, I once had an attorney general for the state of Nevada. I was the medical director of the state of Nevada decades ago. And she was like, Wendy, if you can tell me why you're doing something, I'll defend you in court. I'm not saying to do something wrong by any means, but sometimes you just get to a point where you realize what's right and what people need. And you have to figure out how to make that happen. Because what we were doing in the field was pathologizing a lot of times very normal
relationships.
Yeah.
Relationship
and
building.
a lot of our patients have had magical experiences in our programs. They've felt love and care and attunement in ways that were completely new to them. And then they've, had breakthroughs and moments of incredible growth. And then we're sort of pretending it's taboo, to have contact afterwards. And so this is sort of my own evolution of recognizing these are normal developmental human needs. And it doesn't mean we're creating codependency, and it doesn't mean we're not fostering continued growth beyond our program, because we absolutely are, and undoubtedly. But at the same time, we have, within now we have 6 different alumni cohorts. And it's just done really thoughtfully. Obviously, we have to assess risk, and if somebody needs more help, make sure they get it. But I think it's really much more natural for people to go through treatment than have some kind of access to again, those pillars or the anchors of recovery and each other that help reinforce that.
So it sounds like, in a way, remote services really provide a way for this continued alumni in a way that might be more difficult in person. So that may be one of the advantages. Are there other advantages that you'd like to speak to, as well as disadvantages?
Sure. I mean, that is really true what you just said. I'll go to some other advantages, but that is really really well said. Thank you. Having the app that we've developed, that's sort of the anchor of communication, which we have an app that, family or referents or patients can also have, but we're also our alumni app. So you're in our care and you're used to communicating through the app, but you still have the app when you leave. There's still a mechanism of staying connected once you're in the alumni, but it is sort of a familiar thing. It's like a thread that still continues on. And so that's been a really nice advantage. And by the way, on that note, we also are doing a very good job, which I always want to do better and better, but we're doing a pretty good job of getting post-discharge measurement-based care. Wow. Because we're having better access to the patients. And so we're finding, getting back to your question about advantages. So, when the patients are at home, right, in real time, they're actually having to tackle their areas of their life that they struggle with. So I always say you can be at home and in treatment. We have to teach people, hey, you're actually in treatment. You're home, but you're actually in treatment. So if you go to a treatment center, you're like, oh, I walked in the door. I'm in a treatment center, right? So your brain is aware, I'm in treatment right now, right? But when you're home, it's, wait, do I go to treatment now, or can I watch reruns of Star Trek? It's it's easy enough to just be oh, my dog needs to go out, So to get people really to take it really seriously, I am at home and I'm in treatment. And then the struggle is the opportunity here, because the areas that they're struggling are right in front of us in real time. So as we're working through these issues in treatment, they're not having to then go to a new team and switch environments. We've been tackling what is their life while they're in treatment. And so I think that's why our post-discharge outcomes are showing that, and this is super uplifting, but they're showing continued improvement. People are continuing to improve after they leave within. And instead of that going away, getting stable over here, then like leaving, and then like, boom, you're in a new environment, new team. You go from a lot of times 24-hour care to like, if you go from residential to PHP, and typical PHP, not the way I do PHP, but typical PHP is 24 hours, then 6 hours. That's not rocket science. That's not going to work. Like
It's a
a
huge
lot of
jump.
people, why do we think that would work? I don't know. Doesn't make sense.
I love that you commented on that, because I think that was part of the nascence of Very Even, was seeing people can go through this continuum of care. And then what happens when they get home and they don't have the support and now they're fully independent? I mean, you're right. Not only do you have physical reminders of what you used to do behaviorally or from a mental perspective in those environments, but now you have only one appointment a week, maybe with someone ED informed. I mean, it's so real. That was something that the whole field, I think, just accepted for a long time, of
I know
higher
you
level of care.
a lot of those questions with Very. You just like made it, one-stop shopping to put that team together is like a huge relief. I mean, honestly,
Thank you, Wendy. If anything, I'm like, can I start praising you for Within? Because honestly, it's my favorite company.
Serious. Before I started Within, I retired. That was pretty funny. I supposedly retired in 2016, and then I started doing some private practice, and it was just like, it was amazing to me, because I mean, I'm so spoiled by having a multidisciplinary team like all together in my milieus and stuff. And then I'm in private practice. I remember this like teenager, I was trying to get the whole team together to talk, because she had an eating disorder, but she was also an athlete. And so the whole team needed to talk about like her return to sport. It was Herculean to get everybody together.
Good word for it. Good word.
Oh my gosh. So it's like, yeah, to have that one-stop shopping for a multidisciplinary team that's also cohesive and under the same, kind of principles is really important.
Good problem solving, right? Updated problem solving. It's really much more convenient in that way.
Yeah, absolutely.
I'm curious then, since you've seen this transformation of really how we understand eating disorders as pathologies, how we better understand what someone needs to really have their individualized recovery, what do you see looking ahead too? I mean, I know that there are lots of pros, there could be some cons. I'm just curious your thoughts there.
Well, I mean, I think we could talk about, okay, so the pros and the cons, and then sort of like what's ahead. I mean,
yeah.
I think, again, one of the things that's so advantageous about remote care is the accessibility of it. It's just so much easier to access the care. So I think that the person can get care earlier in the course of their condition too, because what happens when it's really, really hard to go to care is like people put it off and they put it off, and then they have to get so sick to get to the threshold to act upon the eating disorder, because they have to give up so much to go to treatment. So they struggle and struggle and struggle, and it delays treatment. And then that delay of treatment just places a greater burden on them and a reduced quality of life. And it's very, very unfortunate. So we really tackle that problem and get early onset, so we can work with lower acuity, earlier onset, stabilize that person. And then we can also prevent a lot of times the need to end up going to residential or hospitals by providing that care. And then, a much softer landing when people discharge out of residentials. And it's really, really great to see how the team can work together. And I will say not all remote PHP and IOP is the same, just like not all residential is the same. And I think being very intentional in the way we do the meals, and we do support up to 10 p.m. in their time zone, and support in between groups and monitoring, and all these other things make it very different. But the feeling is almost like a lot of the things that you have when you're in residential are actually available to you in your home. The nurse, the psychiatrist, the care partners, and things like that. So one of the advantages there is just like makes the softer landing. And what we found is that there's many patients who you might think they're never going to recover in their home. You have to like take them out of their home to get better. And that's why we were so committed to measurement-based care. Is like, we got to see really objectively what's happening, and are they weight restoring, and what's their scores doing on their EDQ and everything. But, I feel like patients really appreciate receiving care in their home, and they bring their best foot forward because they're like, wow, so they appreciate it and they invest and they do this really hard work. And it's through the relationship that we get what we get out of them, and the honesty. And some people say, well, how do you know? La, 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 la. Like, well, it's a relationship. Like in brick and mortar, people hide food under the table or in their pockets and things like
Yes,
that.
they do.
And how do you figure it out? It's not because you force it, it's the relationship. So I think people surprise us with the responses that we get. Like I had this patient with binge eating disorder, and she's like, I absolutely cannot turn my camera on. I will not eat in front of other patients. So I had to call Dr. Sean, and be like, we're going to bring this patient in and we're going to let her eat off camera first. And this woman was in our care for like 8 weeks. I mean, she had an absolutely transformative life experience. So can't always know who's going to like do well. But then there are some people that just can't do well in this environment. And those, I always tell the team, if we help them get into an environment that is helpful, like that's a success. Like we shouldn't feel like we screwed up. Like sometimes we get people into our care that would just absolutely refuse to go to care, who did need more care. And we'll consider it a treatment success if we can help that person make that.
I think it's so helpful too to really name meeting the patient where they are. I love that example of allowing the patient, even though it wasn't protocol, to be off camera. It's like baby steps. If you do 1 degree of change with behavior, even with just 1 degree, the endpoint once you move out over time is going to be different. And we talk about harm reduction a lot in mental health. And I think you're practicing harm reduction with that approach.
Yeah, it really is. And that's a shift for me. I think the field in 20 years or so, 20 plus years of doing this, I've seen the field change in a lot of ways that I'm very pleased about. There's a much greater awareness of weight stigma. That was something people didn't know anything about until, we really started putting weight stigma and weight stigma awareness like on the map when we started that. It was in the field, but it wasn't really widely understood. So I've seen a lot of like progress in the field in that regard. We have this group within called Beyond Binging, and it's for people with binge eating disorder. And when I heard the name of it, we have this binge eating disorder kind of task force. And I was like, oh, I don't want to call it Beyond Binging because that's just the outward behavior. And it doesn't really capture the complexity of like what people are dealing with. And so I came up with some other name I forget what it was, but I thought it was a great name. I don't want these people to feel like we're just addressing their behavior. So the team took it back to the patients, right? And they were pissed. And they were like, we want to call it Beyond Binging because they felt like me trying to shift it away from binging was like almost due to my own stigma of the word binging. And they were like, we want to own it. This is binging and we're not going to like shy away. And I was like, okay, all right. And the team was like really enthusiastic about that. And that made me realize that's really progress. So I was happy to see that. I've seen weight stigma and fat phobia be alive and well in our field, but I've also seen trailblazers. I've seen a lot of younger clinicians that are very conscious of the needs to address size diversity and weight inclusivity and the concepts of health at every size. And they're this very socially conscious, like empathic group that really takes it upon themselves to see eating disorders in this like sociocultural way as well. And they're just like badasses. And I'm just like, okay, I'm going to go ahead and pass you the torch.
As you talked about, not all hospitals are the same, not all outpatient treatment centers are all the same, not all doctors, not all therapists, not all dietitians are the same. And we're improving in general as a field, and there's cause to be optimistic.
I think so, yeah.
And reclaiming the word binge reminded me of like reclaiming the word fat in the fat community, right?
Exactly. That's what they were doing. And it was super enlightening to me that they really resisted that suggestion.
Well, that's really optimistic. And it's so helpful to hear how you've trailblazed and how you're also incorporating feedback from patients. And I was thinking how incredible this resource is for rural clients as well.
It's just unbelievable. Yeah.
What an amazing, stupendous change. And since we're wrapping up here in a few minutes, I would love to hear more for those who aren't familiar with your company about a little bit about the origin, how you're bridging the gap, and what you'd like to tell our community about what.
Thank you. Yeah, I didn't really get into that. So our program is called Within Health, and it's an intentionally remote program for specifically treatment of eating disorders, and it is an enhanced partial hospitalization and intense outpatient program. So it's available now in about 42 states, I think, and it's JACO accredited, and we are fearlessly working on getting in network with as many providers as possible. So if people are interested, absolutely call us, because we are in network with some major providers now, and that's changing all the time. We also work with SCAs and out of network. So we really are trying to bridge that gap and make care accessible. Our motto is everybody, everywhere. And we're expanding to all 50 states, but we treat all forms of eating disorders. We have an absolutely marvelous RFID program. We have a very significant population of folks with RFID and RFID process group. We have wonderful different cohorts. We have mature adults. We have clinicians with eating disorders, male with eating disorder, BIPOC. Like, we really do follow the patients, like, with what we have, and create those milieus for them. So, an RFID person isn't like one of, 20 patients. Like, they have their own core. I love working with the clinicians that have treatment issues that haven't been able to go to treatment. So yeah, bridging a lot of gaps, I think, is a good way to put it. And we're just honored because the patients give us the access to the most sacred parts of themselves and share that with us in their healing journey. They work really, really hard and bring us so much, like, struggle and incredible joy to the team. So we're very lucky.
Well, the other thing is, what ages do you guys serve with
Right. We are able to work with all genders, age 13 and above.
Amazing. Ugh, just love it. I mean, thank you for all you've done, all you're doing. And I honestly, when we were saying where will the field be in 20 years, I'm hoping you will retire, because you've earned it, quite truly.
A lot of work to do. There are a lot of gaps. There are so many people that need help. So it's just such an honor, both Dr. Knopf and Dr. Oliver-Pyatt, that you both have created such incredible resources